So these are 3 cases of the same diagnosis, something that I think we've all seen many times, but I still struggle with the final diagnosis. So here's a gentleman, and I'll just show this is the only imaging we have on this patient. And it looks like he has bad emphysema. Some of this could be, I mean, you can argue maybe 1 or 2 of these are cystic, but most of them have clear internal structures. These are kind of blown out lobules. So the interesting thing is that this guy is a never smoker, never smoked cigarettes 1 day in his life. So I'll show that case.
Can I ask a question?
Sure.
Does he get hives?
Oh, I don't know. That's a good question. Why? What are you thinking?
Oh, hypocomplementemic urticaria vasculitis.
Yo, right. No.
Okay, I can imagine you had 3 cases, but if anyone did,
Well, we
you
do.
would.
We do have. We have like 8 or 9 cases of that.
Okay, see.
Something I've never seen before, but now I know about it because
Yeah, because I showed one of those like 3 or 4 months ago, maybe
Right.
a
yeah,
little
yeah,
bit longer now.
and I had literally never heard of it, and then I was talking to Lynch about it. I was like, oh yeah, we have a whole thing of the cases here, and I'm like, okay, that sounds great.
Is that a cause? Is it a cause of emphysema or what?
Yeah, it's a cause of kind of dramatic emphysema in non-smokers. I don't know what is it. He said that and chronic recurrent hemorrhage can also do it. I don't know what the cause is in the hypocomplementemia is. Let's see. Do you guys know what the cause is in the hypocomplementemic?
No.
So here is another case. So here we look, and it looks like here it's more ground glass with the cystic emphysematous stuff. Again, this guy, never smoker. So here he is in 2018. And let me show the study that was done most recently. And, much worsening areas of paraseptal emphysema, airspace enlargement with fibrosis. I don't know what you want to call it. It's not really honeycombing. I would call it airspace enlargement with fibrosis. At least some of this looks like that. Some septal thickening. And then let me go to the third case. And I'll show the third. I have a lot of ones from the third case because we follow this patient up. And I think when I show the most current study, it's not going to be clear. But when I go back, no, that's 2013. When I show the newest study, it won't be clear. But I think when I go back to the first study, then people may get a diagnosis. So here's the third person with never smoker with emphysema. Now this one has a background of findings that you may be able to suggest the diagnosis, because if you got rid of the emphysema and you had kind of this upper lobe ground glass and the lower lobe mosaicism, ground glass system mosaicism, kind of looks like something. Let me go back to the initial
Was there a nodule in that left base?
If there was, it didn't really have much to do with the diagnosis. So here's the first study, and maybe we can tease out some central lobular nodules intermixed in these areas here. I mean, very questionable.
Mm-hmm. So they all have
Anyways,
HP?
they all have HP.
Really?
So these are all people with HP and so I argued with Lynch about this, and I'm like, dude, there's no way, because none of them have path. And I'm like, how do you know it's HP? And he's like, because this has been reported in the literature forever. And I'm like, no, blah, blah, it's not true. But sure enough, with chronic HP or fibrotic HP, whatever you want to call it, there is a transition to emphysema in a small percentage of people. It's been initially reported, most frequently reported with farmer's lung, but in non-smokers, but it's been seen in other forms of HP. All these patients own birds, and all of these people had, again, whatever an antigen sensitivity is. I mean, everyone who has a bird is going to have some sensitivity or antigens to that bird, but the clinical radiologic diagnosis, there's no pathology, and all of these are HP. And again, I kind of argued about it with Lynch for a while, and he's like, and he showed me, again, 3 or 4 papers, older papers, that all talk about emphysema in HP.
Was there
So-
anything in particular about their exposures? Because you said mostly farmer's lung, which may just because it was more common, or could it be related to exposure to a lot of gases or something, in a farm,
No.
whether it's diesel from a tractor or something?
Yeah, those are all fair questions, and I don't know the answer to that from these papers. I could forward some of the papers, but they do talk about people initially having kind of more earlier on having a more classic HP picture, and then over time progressing to emphysema. I'm still trying to wrap my head around it. The issue with a lot of stuff here is that we don't get pathology. It kind of is, they have an exposure, the imaging could potentially fit and it gets called HP. And we have a lot of cases like that. But I don't know. I just find it to be discomforting. But interestingly, most of them have lower lobe emphysema. And again, these are all never smokers.
So maybe it is better to describe it as fibrosis with airspace enlargement rather than emphysema. Because that just
But the issue is that not all.
It doesn't look like emphysema.
That case I agree, but this one, I don't think you would call it AEF. I mean, it just looks like emphysema. That other case I agree. That one I'd say, airspace enlargement fibrosis. This one, has these little, yeah.
Very curious.
It is very curious. And then lastly, not as exciting, but just had this one. Just a nice example of, it's not a hard diagnosis to make based on the lymphadenopathy and some of the nodularity, but it's just a really nice example of profound septal thickening secondary to sarcoid. So this septal thickening had been present and really unchanged over many years, presumably secondary and we know that sarcoid is an uncommon, but definitely a cause of septal thickening. And this is just a case where there's really pronounced septal thickening as one of the major findings. And,
Interestingly, basal predominant and symmetric.
Yeah. And the airways are very funky and distorted, and he had bad tracheobronchomalacia, but yeah. So, okay, those are my cases.
Thanks. All right, Travis, you wanted to go next.
Yeah. Hey, Seth, hopefully you can stay on at least for this first one.
Yeah.
All right. You see my database screen?
Good.
Yep.
Yeah. So, okay. This case and a discussion I had with a colleague kind of challenges this whole concept of intimoIntimal intussusception. And this is a patient, as you can see, that came in with a dissection. And some of the flap has balled up into the right common carotid artery, which is why the patient presented. They presented with a stroke. And the question I have, because my understanding, if you look at the literature, was that when you have an intimoIntimal intussusception, which I think some might say this is because you've got a whole bunch of intima that's balled up here, that it's been described as being due to a circumferential tear. And, after discussion with the surgeon, they're like, no, these aren't circumferential tears. It's not like there's a 360-degree tear and that the entirety of like you have no intima in this area. It's more that it's a longitudinal tear so that you do get a flap of the intima that then goes and balls up somewhere like this. And I'm just curious if you guys, because Seth, I remember you showed at least one or a
Yeah,
couple of these, and
couple. Yeah, with and Howard
yeah,
showed talk about the empty intima sign or something where the
yeah, right,
aorta just
The
dilates and
aortic
there's no
sign.
flap there. Um,
right. So
my guess,
because
yeah,
the yeah, because the surgeon was saying it's like you still have intima along some of the wall, you just get longitudinal tears along a portion of wall that creates basically like a longitudinal flap that then is free to go
like a fruit
somewhere else.
like a fruit roll up, kind of rolling up and
Yeah, that's actually, yeah, that's a good
kind of like
description.
a yeah. I mean, I
So
would imagine there's lots of different ways. I mean, I
yeah,
because the circumferential tear is talked about in the surgical literature. Maybe there's just different forms of it.
maybe. Yeah, maybe it's just not as simple, it's not like I think that's probably correct. That it's probably not just one size fits all. So I don't
Yeah,
know,
that's
but this one,
I've never seen one that has had a like a dissection flap like that with an associated intimo-intimal
yeah.
intussusception.
Okay. I mean, regardless, whatever it is, but you clearly see why this patient presented with
He's got
a
huge
stroke
coronaries
since
too.
I know those are really big coronaries too. I don't know
Yeah,
why. I mean, there's motion here. I mean, don't this. Fortunately, this patient was not a surgical candidate, and they had a massive stroke. So
yeah.
unless their neurologic symptoms improve, they're not going to the OR.
Can you go down to the aortic
Oh,
root and then go distally slowly, starting from below? Okay, so there's a flap there,
yeah,
and
and
then
the primary entry tear is right. There is a tear right in here. I think you can, you know, zoom out a
what
little. I think
about
that'll actually help.
what about
Yeah,
some
and
of
then
the
as you,
flap going up in there? But it's also as if maybe there's, I don't know, thrombosis of that carotid artery more than just a flap, because the entire lumen,
yeah,
well, there is a flap going up there.
No,
Then it
there's a
becomes
flap.
yeah. There's
completely
Yeah, there's a
opaque,
there's
flap
a
there.
there's a flap that
as if
goes up
there's,
into it,
yes, there is.
and you can see that's flap,
And
and then you do have there's a whole bunch of aorta that has no flap here, and this just kind of flopping in the breeze right there. So yeah, I don't know. I just saw this recently, and it brought up that whole discussion of what the whole concept of an intimo-intimal intussusception is. So
but there isn't a portion of the ascending aorta, as best I could tell, that was free of a flap for any distance,
the
I think.
no, the arch was though. There's a portion of the mid arch here. There's nothing
Because
between
usually,
here.
right, but
Yeah,
usually if there's a flap there, one would think that it would prolapse distally down the aorta, not go backwards, as it were, into that carotid, because
I don't
blood
know.
flows
I mean,
in the other direction. So that's odd, isn't it?
you would think, but I've seen, cases of mobile thrombus, like adherent thrombus here, that flipped back up into the right brachiocephalic artery. I know I showed one, it's like, I don't know. I
Okay,
agree with you, Howard, but
odd,
there's,
very odd.
yeah, exactly.
So, Travis, are just to back up to a very basic level, are we sure that this isn't just extension of the dissection flap from the aorta into that right carotid artery? We really think that
And
this intima is coming from a different location and is lodged up there rather
I,
than is native to that artery?
that's a very fair point. I don't, I just saw this one with what looks like some of the flap balled up in the carotid and wanted just more to discuss in general.
Yeah,
I
the
mean,
way it's tangled, it looks like tangled and folded up. That would be really weird
yeah,
unless it what. And I'm looking at like a couple surgical papers, and they describe it as a complete circumferential. I mean, here's one from Hopkins from from cardiac surgery.
Can you put that in the chat? That'd be great to
Yeah,
or
sure.
text it to me.
It's
Thanks.
it's a case report, but I'm seeing case
Yeah,
reports, but
but
I'll put it
still.
up there. Yeah.
Yeah, I think these are all case reports though, and probably my colleague was just talking to a surgeon who had one case report where it was more of a longitudinal thing, like a fruit roll up, like you're saying. All
I
right, this
personally
one.
encountered one with an intimointimal dissection in which the primary tear, circumferential, was in a location other than the ascending aorta, typically aortic root. So that's odd too about this case.
Yeah. All right, here you go. So is this is an interesting lateral. So the most recent one is on screen right. So I just won't say anything and let you guys
Looks like a tummy
see what you
problem.
see. What's that?
Tummy problem.
Very good. Yeah, this was not called prospectively. I mean, this is a couple years ago, and I just saw this anyway. Right, so it could be an intrinsic tummy problem, or it could be an extrinsic tummy problem from something behind it, which is what this turns out to be. But you are exactly right,
I would
David.
have never
You
called
don't.
that in a million years.
No, it's fun. It's
Yeah, no,
good
it's
to
there.
see though, right?
Yeah, no,
Yeah.
it's there.
So
It's just, man.
and actually, I'll zoom in so you can see they do have some surgical clips, which are in a way unrelated to this, but they've had a prior partial colectomy, and it all ties into their underlying Lynch syndrome and their whatever tumor suppressor gene mutation. And this all turns out to be this is part of the tumor, and it's all a big adrenal cortical carcinoma from the left adrenal gland, and there is invasion of that left renal vein and then across into the IVC. It's all contiguous. I just didn't download the MR. I just have the PE study. But
Guys.
yeah, this was more, I totally agree, Seth. I think that, you know, now that I've seen one of these, maybe, but I'm still going to miss it.
Yeah, it's a great call. I mean,
Yeah, this is just retrospectoscope to show everybody. All right, this one, you know, not as much. There's been a rash of good lateral cases lately. Um, this one you can probably see on the PA view, but if you
Something
don't,
protecting over the lower trachea.
yeah. And of course, you know, in the lateral, it stands out much better. And this guy's, don't remember, 60s or 70s maybe. Um, and you'd think it's a squamous cell carcinoma. You know, it's a little slightly pedunculated maybe. And this turns out to be the pathology on this was an adamantinoid-like or adamantinoid tumor with Ewing sarcoma-like features or something
Oh boy.
like
Oh
that.
gosh. Okay.
Adamantinoma like Ewing family of tumor of the trachea.
aren't those
So
like aren't those tumors you get in the jaw,
Yeah.
adamantinomas, right? Don't those you like?
yeah.
Yeah.
That's
So
yeah.
I don't know.
There we go.
That's yeah. There you go, Seth. I don't know. Send it to the AFIP.
Yeah.
But it's just again the fun lateral. This one waiting on the confirmation, or we'll see if anything grows. So this guy did come in recently. He's 35, has a history of several weeks of weight loss. He's not from the United States originally, B symptoms, and he's got the pleural effusions, maybe a little bit of pleural thickening on it, right? But I think that's just intercostal muscles. But unquestionably, you know, huge pericardial effusion with pericardial thickening. And you can see now at this point, if this with this being chronic, you know, I don't know how much where you draw the line between tamponade and like effusive constrictive pericarditis because he had some septal bounce on the echo. He's got flattening there, massively dilated azygos or IVC. And check this out. So this was definitely an upper extremity injection because you can see the contrast being injected through the right upper extremity. And
And it
yeah,
just
I'm
goes
not
straight
crazy
down.
about what's that?
And it just goes straight down.
Well,
The
yeah,
contra-
and I'm not crazy about IVC reflux, but
yeah,
you know,
this
if
goes
you were
straight down.
grading this reflux, it
Yeah.
keeps going, it keeps going, it keeps going.
Oh,
It
wow,
goes
that's
all the way into
nuts.
the pelvic veins.
Oh, that's crazy.
Yeah.
That's
And he also has an abscess, presumably an abscess in the right rectus muscles there. So we're
just
thinking this is
tuberculosis.
probably TB. Yeah.
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 And then I think all of the peritoneal cavity is probably sterile, and this is probably all just congestive lymphadenopathy or congestive lymph nodes there. You know,
Yeah,
we're
that's
waiting on cultures, but
yeah. Effusive constrictive is usually not even this big. It's not even like a huge
yeah,
effusion. That is really impressive.
yeah. I mean, they just called it concerning for tamponade on the echo, but I was like, and again, that's why I don't know where you draw the line between, you know, one and the other, but
Yeah.
in a case like this,
No, no lung findings for TB.
good question. No, nothing, you know. He has some atelectatic lung, but in what we can see, no. So we'll wait and hopefully get an answer. Um, and then, you know, again, I found a lot of good anatomy cases recently. So here's one, you know, the azygos arch should jump out at you. It's just a portable. He's semi-upright or upright. And then you look back at the CT and you can see it's just an enormous azygos vein. And he does have or he or she does have azygos continuation of the IVC. And I think this is congenital, not acquired. But I think the old radiograph is interesting, particularly the lateral, because you can kind of see the azygos arch here, but it's obscured by the trachea. But on the lateral view, I think you can see it right there, some of it, you know. And I think there's a second lateral that actually I think you guys agree that probably explains that extra
Yeah, I think so.
Yeah,
convex,
that's
Yeah,
that
good.
extra
that's a good
interface right
location.
there.
Right.
Yep.
Yeah.
Does he
So
have normal bronchial anatomy?
good question. I didn't even get around to looking at it. Let's see. There's right upper, right looks okay. Left looks okay as well.
Okay, so no
Yeah.
isomerism.
No, I think this is just an isolated, yeah, not a part of a congenital spectrum or
Right
any
number,
sort of
correct number of
heterotaxy.
spleens, right? Only one
Yep.
spleen. Yeah.
Yep. So again, just a nice lateral view right there.
Yeah, very
And then
nice.
we'll finish off with one, you know, one more lateral just for fun. This guy, atraumatic, gradual swelling and pain. And I think they
Retromanubrial,
did.
retrosternal.
Yeah.
Yeah, well,
It's like a
yeah,
sternal
exactly, Howard. And
fracture.
interesting too. It's both pre-sternal and retrosternal.
Ah, yeah.
And this there's no fracture that we can really see here. He didn't have a history of trauma.
Just
Um,
infection.
that would have
Chondrosarc?
been the yeah, that would have been the best bet was or you know, best hope was infection, but
Uh,
this I guess this did get biopsied at the outside. Yeah, and Jeff, you're exactly right. It's a chondrosarc, you know, which means it must have primarily arisen from one of the cartilaginous junctions, or like,
Oh, probably
or
from
do
the
you think
sternum.
I
I'd
think
say
from the
from the sternum.
sternum. Yeah, me too.
why
It's
would it not be an
very common.
osteosarc from the sternal body? I mean, it is a chondrosarc. I'm just
Yeah.
curious.
Well, I've seen quite a few from arise in the sternum proper, but you see that nice
Okay.
chondroid matrix. But what's interesting is when it gets into the soft retrosternal space, I bet it de-differentiated because you've lost the matrix and it's more just kind of necrotic soft or
Yeah.
just soft tissue.
Yeah.
Hmm.
And then there's a little bit of extension anteriorly there, which I think is probably what he was feeling. So,
Hmm.
all right. So a collection of more interesting radiographic findings and somewhat obscure diagnoses.
That's great.
Good cases.
All right. David, you said you didn't have any. Howard, do you have anything?
I do. Phew.
All right.
All right, here's the first case. read this as if you were just reading another exam in a stack of outpatient radiography on any afternoon of the week. Anyone see anything interesting if it came up like that? Or a place that I should focus on? So I'm going to come up here now. Here it is. So one of my colleagues in abdominal imaging showed me a case like this several years ago, and he said it's very distinctive. So calcifications in the spleen, obviously a lot of them, and this is what they look like. And he said, SLE, next case. And I'd never heard that before, never seen that before. He said it's super distinctive for SLE. So let me bring up the, I think I had this here. Not that, obviously, this one. So diffuse calcifications of the spleen like that, novel association with SLE, unique pattern of splenic calcifications, just like that. So next time you see that, just go straight for SLE. I have no idea why they form in that fashion, but there you go.
So that's
Apparently
different than
distinctive.
the diffuse, I mean, like we see with histoplasmosis, where you get tons of little
I don't know,
calcifications.
just so many of them.
Yeah, this is,
So
I've seen it with
many.
sickle cell, but only when the spleen is like all shriveled up.
Yeah, I'll go back to that radiograph. Very impressive.
Yeah.
Yeah. And he said he's seen it a couple times and he recognized it right off. So acute case of something that's supposed to be distinctive. This is great for our trainees. If you're reading a stack of radiographs, sometimes findings like this are a little bit hard to perceive. It's not large. So here, look for an abnormality. Heart, mediastinum, lungs, kind of subtle, but here it is. So here we have beautifully symmetric opacity in the medial portions of the upper lobes. And clearly it goes at least from here to about there somewhere, and from there, and then the rest of it is obscured. So typically, I teach that when you see symmetric, particularly apical paramediastinal opacities, more up here, think of radiation therapy. Think of radiation therapy for treatment of neck cancers, maybe mantle radiation therapy. But here the hyla are not elevated. So if neither of those is pertinent, then the symmetry is still very suggestive of radiation fibrosis. And this was radiation fibrosis for treatment of a vertebral metastasis. So let's go to something like that. And here we see the symmetry very nicely. And this vertebral body over here was involved with a metastasis. I can't remember the origin of it, but localized radiation therapy, upper thoracic spine, symmetric opacities, pleural fluids also present at that time. Here's an interesting patient with, I don't know exactly what symptoms. Let me just get the timing. This is 3-1, going back in time. So I'm going to assume that the person had a troublesome and a persistent cough. There is a history, presumably for treatment of cancer, of a gastric conduit. And you can see here, image pre-protocol. And let's go down first, lung windows. And we can see there's a lot of abnormality in the right lower and middle lobes. If you look carefully here, may be able to appreciate that a substantial portion of the abnormality is actually intraluminal within the lumens of proximal generations of bronchi, as well as distally, particularly in the right lower lobe, but also the right middle lobe. So very suggestive of an aspiration phenomenon. And now we have to look carefully to see if we can see a connection between in this case, the gastric conduit and airway. And sure enough, here it is. So here we have a conduit to airway fistula right there. And I don't know that that is a malignant fistula. I don't know why it developed, but very consistent with an aspiration syndrome from a fistula. So gastric conduit to central airway. This is really interesting patient. So we go back many years. I will tell you over time, eventually the patient had a unilateral lung transplant for fibrosis. This is what the lungs looked like in 2015, and an extensive fibrosing lung disorder. I don't know why there's a large cystic space in the left upper lobe, subpleural cystic spaces. I don't know if there's a history of smoking or not, but clearly a very severe end-stage fibrosing lung disorder. Patient had transplantation. Post-transplantation, this is the following year. We can still see the findings that I showed you in the left lung, transplanted lung. Now let's go forward in time. So this is 2016. Again, we can see that at least at this point in time, the amount of fibrosis in that left lung looks about the same. The transplanted right lung looks okay, 2016. Now we go forward to the more recent one, which is going to be down here. So 2020, 4 years. And here is the dramatic appearance. I think the patient may have presented with a spontaneous pneumothorax because there was a chest tube in, but remarkably, look at the spaces in that left lower lung. Innumerable, large, profound honeycombing, and many, many of them are filled with presumably mycotomas. They're just fungal spores filling in so many of those spaces, the most that I've seen. That is impressive. And I don't know why the fibrosis progressed so extensively to make these large cystic spaces, but that's the most impressive case that I've seen of that.
You know, it's almost like a variant of, and you and David have probably seen this, the obstructive bronchial aspergillosis that was seen like during HIV before it was a treatable disease. You know, where you get these large aspergillomas growing in the airways, and I wonder if it's just like a similar phenomenon. You've got an immunosuppressed patient, and there's these spaces, and they just grow.
Yeah, remarkable.
Yeah.
I don't think that patient had, as far as I know, hemoptysis at this time, so I don't know what these focal lobular ground glass opacities actually represent. As far as I recall, hemoptysis wasn't the clinical presentation as such at this time, but there was a pneumothorax and they put in a tube. So presumptively just innumerable mycotomas in those cystic spaces right there. I can't think of another plausible explanation for it. Okay, this is a really nice case for our resident. So here is the history of a snowboarder. Fell on his back, I think the day prior, if I recall correctly. And I don't know to what extent he had shortness of breath or chest pain. You can see here on the left-hand side that he had a rib series. And let me look at the timing. So that's 5/16. And yep, it's all on the same day. So particularly trainees, take a look and see if you see anything subtle. This is the kind of case that, for fun, I would call trainees over and say, okay, here's a $1 case. See if you can make the finding. If you can make it, you get the $1. It's just a perceptual fun case. So it's not rib fracture. And then if they don't get it, I'll just zoom in and say, okay, I'm going to draw your attention to up here. And right there, right here, even here, there's a bit of subcutaneous emphysema. But the more you look, the more you recognize that there are streaks of air in the mediastinum traversing the thoracic inlet. Yes, it's subtle, but again, once you've seen it, the more you look, the more you see. Maybe there's a double wall sign of the trachea. I'm not sure about that. But a very nice case of pneumomediastinum, undoubtedly the Macklin phenomenon in a snowboarder fell on his back. So pretty typical mechanism. And he did fine. Okay, let's see. Veno-venous ECMO. I've seen so many different ways that surgeons approach veno-venous ECMO. So here, for example, if you see one cannula, you say, okay, I've got something in the jugular vein. What else do we have? So let's go and have a look. And let me bring up something here. And then you can see something's coming from below, or what's in and what's out, all kinds of tubes going different places. So over time, things change, but ultimately they were doing, and I'm not quite sure why, they were doing veno-venous ECMO with one cannula in the jugular vein and one in the IVC. And I'm not sure why they did that, but just one way to do veno-venous ECMO. I've seen a situation where they put two cannulae up the IVC for veno-venous ECMO. If you see that and you have two cannulae, the idea is that the two cannulae, the output, should be separated by about around 10 centimeters between both cannulae so that you don't get a recirculation phenomenon. But sometimes it's hard to pass these out unless you have clinical information. So one cannula from below, one from the jugular vein, veno-venous ECMO, extensive pulmonary disease, hypoxia, and so on. So one flavor of veno-venous ECMO. I think that's it. Let's see. Oh, what is this case? Okay, so I think this is, okay, mediastinal mass. Pretty typical. Mediastinal contour abnormalities. We have a big mass, and it's very homogeneous. It doesn't have much in the way of heterogeneous attenuation. So if one is thinking of a primary germ cell tumor of the mediastinum, I would go for a seminoma rather than a non-seminomatous germ cell tumor of mediastinum. And now I need to reveal this just so I can remember which this one was. Seminoma. Okay. Okay, and then one last one. Prior for comparison, this is a time when, as best I can tell, the patient had a cough. Now there is some diffuse lung disease. I'm not sure what the etiology of that is, but we have this radiograph in combination with a CT on the same day. And I'm not quite sure exactly what was being thought of, but let me fix that. Go back to default. And you'll see a surprising amount of abnormality, localized abnormality in that right lower lobe. So this is an elderly patient with apparently a new cough. So let's go first all the way down here. There's a lot of emphysema, maybe emphysema and fibrosis. But there's a lot of abnormality down here, in particular in the right lower lobe. And then in looking at the airways, again, trainees, always pay attention to the central airways, follow them back, make sure that they contain air and that they're continuous. Because if they're not, like in this patient, we go here, bronchus intermedius, we go down, we have the right middle lobe bronchus, that's patent, and we go down, and then we're looking for the patent common right lower lobe bronchus over here, but we don't see it because right in here, that airway contains a large, high attenuation object. And yes, in speaking with the clinicians, they agreed that aspiration of a pill is probably the most likely culprit. So this is an aspirated tablet pill in the airway right there.
Did they pull it
And
out, or they just let it?
I can't remember, Seth. I can't remember. Can't
It's like
remember.
I don't
I
think I've
remember
seen that.
calling the physician outpatient, and they
Yeah,
were going to refer the patient. So I don't know what happened.
sure does look like a pill. Interesting.
Sure does look like a pill. Yeah, it does. Yeah, very attenuating. Okay, Jeff, those are
All right.
mine.
Thank you, Howard. Those were great. A lot
Great.
of good anatomy cases today. I like it.
Yeah.
Let's see. All right, I have. Let's see. I should see my screen here in a second. All right, you should see my database. So I have 4 cases. They're all interesting vascular cases. So this first case is a guy with who has idiopathic pulmonary hypertension, and this is him a while back. And at this point, you can see he's got a dilated right heart, some RV thickening. PAs are a little on the plump side, but you'll notice the pulmonary arteries themselves look pretty good. Now, if we jump ahead to this scan, this is the most recent one. His PFTs were getting worse, and they got a CT scan. He's developed some left heart failure. He's got some effusions and edema. He also has some central lobular ground glass that may or may not be related to his pH. But what I thought was really interesting, I know David will like this because this is what I learned from him, if I can get the right window here, is he's developed these atherosclerotic calcifications of his pulmonary arteries. You can see them on the intimal, where the intimo would be of these of his pulmonary arteries. So he's had long-standing. I think the time between these was 5 years between the scans. So over the course of 5 years, and he's on vasodilators, he's developed atherosclerosis of his pulmonary arteries. And I've only seen that in people with really long-standing pulmonary hypertension. So, but I've not seen it actually develop. So that was kind of neat. I don't know if anyone's ever come across that before. But if you ever do see these calcifications, it's usually indicative of pulmonary hypertension. All right, the next 2 patients have the same underlying diagnosis, but different complications. So this is a patient with a history of ANCA-associated vasculitis with an anti-myeloperoxidase, so microscopic polyangiitis. And the patient presented with shortness of breath and developed this area of consolidation here in the right lung. They got a CT scan, which really doesn't add much, but we can see there's this more confluent, predominantly ground glass, but there's some consolidative components with some spared lobules mixed in there, and then a little bit elsewhere. And so, of course, I mean, we can't be specific for what this is, but in the setting of a known vasculitis, we would think about hemorrhage, acute vasculitis. There is stuff in the airways, and I did favor this being hemorrhage. But you could also consider an infection, especially if they're on immunosuppression. So this was all the inflammatory markers were elevated. So this is a flare of their vasculitis. So this is predominantly pulmonary hemorrhage, complicating that. The other patient has the same diagnosis and also presented with shortness of breath. This patient had been on immunosuppression. I believe they were on very low dose steroids, and I want to say methotrexate, and came in with this CT. And you can see there's some airway stuff going on. There's a cavity, there's some branching nodules. But what was a big abnormality is all this ground glass. You notice it's a little bit, it's more diffuse. It's ground glass attenuation. And then, of course, there's the chronic airways disease. And so this all turns out to be pneumocystis, which even they were a little surprised the patient was only on like 2 milligrams of steroids, but had been on it for some time and had some other immunosuppression. So I still haven't come across really any infections that give you just this nice kind of amorphous ground glass opacity, really, other than pneumocystis. So I still consider it with any degree of immunosuppression, and I don't think people need to be as immunosuppressed as one typically thinks. So it's at least worth putting in the differential. So we have Yeah.
The critical thing in pneumocystis that we found long ago in looking at chemotherapy patients with breast cancer was that all it takes is for your lymphocyte count to drop below 200, and then
Okay.
you can get pneumocystis.
All right.
So I'll bet
Last case here. This is kind of cool. So this is a guy who's a young guy who had a liver transplant. And I want to find it. So here's an old scan. So you can see he's got these really big esophageal varices, and there's bad cirrhosis. And if we look, we can see there's one, we can see right here. And this is an abdominal CT, but you can see there's this varix here that communicates into the lung. So we've seen this before where we've seen communication with the pulmonary vein. But what I want to show is you'll see there's contrast in the pulmonary vein, but then it gets quickly becomes non-contrast. So I suspect it's flowing into the pulmonary vein and then starts mixing with the contrast that's already there. And I just have non-contrast above that, so that doesn't really help. But we've seen that before. But what was kind of cool is, so he's now had a transplant for some time. And of course, his varices are there, but they're a lot smaller. And what was kind of neat is look at the contrast now in this vein. It's actually, so we're early, so we have a lot of contrast in the lungs, and we have nothing really in the portal venous system. So if we follow these veins down here, we can see the contrast is bright, goes into the sort of nest of varices, and then it kind of starts to dilute. So I think what's happened is now that his portal vena pressures are down, this shunt, instead of going up, has changed direction, is now going down. Would you all agree with that?
Yeah. A different direction of blood flow. Very good. Yeah.
Yeah, I thought that was kind of fun.
Very
Yeah, you
interesting.
can see it there. Yeah, this was an interesting case because I guess I don't know if the person who was referred to, I can't remember, one of the surgeons, was not aware of this and had asked about it. And we'd seen this before, and actually it's interesting how it changed direction. So okay, so those are my cases. So
Excellent.
yeah, this was fun. I like this one.
yeah.
This is the best one of these I've seen. And then and has anyone, I asked this, but has anyone ever seen development of calcification in the pulmonary artery intima over time? I've seen it in people presenting with long-standing pulmonary hypertension, but I've not seen it develop.
I have seen it worsen. I don't know if
Yeah.
I've seen it with none and then go to it. I've seen it with some and get worse over like 10 years.
Okay.
I have seen it develop too over time.
Okay.
Yeah.
It depends on how long the person survives.
Yeah. Yeah. These were 5 years apart. So, and the patient had already had pulmonary hypertension for some time. So I guess it's just a matter of time. All right. Well, excellent cases this week. Thank you.